Hello, I'm Norman Swan. Welcome to another program in our series on type 2 diabetes. Today we're going to be talking about primary prevention and early detection and what to do when you find a problem. Type 2 diabetes affects over 7% of the Australian population aged 25 years or older. But for every person diagnosed, there's one person who goes undetected, and that's a recipe for complications in almost every organ in the body. But you already know that. This program looks at new NHMRC evidence-based guidelines, and that we're going to be talking about prevention and early diagnosis, as I said. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Ashim Sinha is the Director of Diabetes and Endocrinology at the Cairns-based Hospital and its Diabetes Centre, and is also Associate Professor and Senior Research Fellow at James Cook University. Welcome, Ashim.
Thank you, Norman.
Mark Harris is a General Practitioner and Director of the Centre for Primary Healthcare and Equity at the University of New South Wales. Welcome, Mark.
Good evening, Norman.
And Alan Barclay is a practising dietitian with Diabetes Australia and also a researcher at the University of Sydney. Welcome, Alan.
Thank you.
And welcome to you all. So, Mark, we are dealing with an epidemic. I know we've said it, but let's just remind ourselves of the statistics.
Well, the prevalence of diabetes is increasing in Australia, but worldwide. We're seeing a steady rise in the number of people with diabetes. And that's related not only to the ageing of the population, but the shift in our lifestyles. That's happening both in developed countries like Australia, but also less developed countries, especially in the Asian region. It's the most rapidly rising disease in the region.
And what about the prevalence of abnormal glucose tolerance?
That's certainly very high. We look at about 7.5% of people having diabetes, but there's another 10.5% of people who have impaired glucose tolerance, and about another 5 or 6% of people with impaired fasting glycemia. So we're looking at over 20% of the population over the age of 25 with either diabetes or who are at high risk of diabetes.
But it's not evenly spread through the population, is it?
No. We know that diabetes is in Australia, the prevalence of diabetes is greater in low socioeconomic groups. So we're seeing, and that's largely associated with the incidence of obesity. So here we can see in this graph a graph of diabetes-related deaths by looking by different socioeconomic quintiles, with the most disadvantaged having the highest rate, and then what we call a social gradient as you move up the social classes to a lower level of diabetes.
Disease of poverty.
Yeah. And that's reflected in their death rates and prevalence rates as well.
And Alan, you've tracked it by geography.
We have indeed. We've done some geospatial maps of the prevalence rates of diabetes in New South Wales, which we believe are broadly applicable to the rest of the country as well. And you can see going from lightest to darkest is increasing diabetes prevalence. And this is the 2000 map, which is the National Diabetes Services Scheme data from the year 2000 and the 2001 census data. And you can see the darker points in the middle and to the west, and then we move forward to the 2007 data, and you can see quite an increase in the number of regions with the darker colours. So the diabetes prevalence rates are rising quite dramatically, particularly in the west and the far west of New South Wales. And we do believe that this is very similar in other parts of the country.
And Ashim, a lot of that will be in, and if that's reflected in other parts of the country, and your experience would be that it is, if you're working in Cairns.
Yes, absolutely. The prevalence of diabetes in the indigenous communities across far north Queensland and elsewhere in the country is almost 3 times as that of the non-indigenous Australians, rising to about 25–30% in some population. And in the most recent study that was done in Darwin, in urbanised indigenous Australians, the prevalence rate is almost about 17 to 20%. And we are seeing the disease more and more in younger people, and particularly in children.
And just frame these guidelines for us that we're basing our discussion on, Mark.
Well, the guidelines are really for the prevention of diabetes, and also there's another guideline for the early detection of diabetes. Basically, we're seeking to prevent diabetes before it can occur. So we're talking about primary prevention of diabetes. And we can think about that in the general population. So we're interested in reducing the incidence of type 2 diabetes in the whole population through general population measures, particularly around diet and physical activity and overweight. And amongst high-risk groups, and this is particularly relevant to clinical practice, increasing the offering interventions for people who we judge to be at particular risk of diabetes.
So we'll come back to that in a moment. Let's go to the results of our poll to find out where you base yourselves. Blue is rural, yellow is remote, red is metropolitan, and green is regional. So most of you identify yourselves as rural, and then you're evenly split between metropolitan, remote, and regional. I want to give you your second poll question. How would you rate your understanding of primary prevention measures? Very little understanding, moderate understanding, comprehensive understanding. So why don't you answer that question, and we're coming back to that. We've got our first question in, which comes from Marissa Pilla in North Queensland, your area, Ashim. I'm wondering if we're missing the boat with our potential diabetic patients. I've had a few patients whose pathology has changed immensely from 12 months earlier. However, the levels were just within the guidelines for fasting blood glucose. They were told all is well. 12 months later, and all are now at early stage diabetes. Could we not have intervened earlier and prevented this from occurring? Ashim, North Queensland question. Might as well go to a North Queensland specialist.
Yes, I think it's very difficult to draw where the line is. I mean, the clock starts to tick very early, and where we have set an arbitrary figure of 7 for diagnosis of diabetes, we also know that people with impaired glucose tolerance and impaired fasting glucose, which is called pre-diabetes, are at equal risk of cardiovascular disease. So I guess if you are in the high-risk group and if you have facets of the high risk, then I think interventions should start early and as early as possible, even if their blood glucose is not within the so-called diabetic range.
And how often is it that you see it speeding? In other words, it's a speedy change.
Well, it is seen quite commonly. I mean, where we come from, we see that quite often that things change dramatically within 12 months to 18 months. Yeah, so that's not uncommon to find, from being normal to from being.
I suppose once your beta cells are beginning to clap out.
Absolutely. The beta cells
you're on the margin.
Beta cells can drop off very fast.
That's a well-known pathological term, clap out, isn't it, Ashim? Sort of Harrison's textbook describes it well. Alan, how preventable is it really? Is type 2 diabetes?
There's actually very good evidence that we can prevent almost 3 out of 5 cases of type 2 diabetes through a lifestyle intervention. So it's very good evidence indeed.
And it's about twice as effective as medication in doing that.
Yeah, surprisingly, we've found that diet and physical activity, getting people to lose weight, in the various studies that have been conducted in overseas, Finland, US, China and India, all of them demonstrate that, at least particularly the ones where they've had a comparison with metformin, for example, that lifestyle change is more effective than drug therapy.
When you can do it?
When you can do it. And obviously...
So you've just described a situation where people who are least able to take control of their lives in Australia because there's so much going on, yeah. They're on struggle street. Are they able to take this on?
It's possible. It's difficult, and the Finns recognise this. I was talking to Timoletto, and he recognised that it's difficult, and we need to make extra effort with people from low socioeconomic backgrounds. But it's possible. It's possible, and we don't have to kind of get people to be the biggest losers and lose mega amounts of weight. It's a relatively small amount of weight that we need in order to really achieve that dramatic reduction in risk, especially in high-risk people.
Alan?
Absolutely. It's small changes add up. We're only asking for people to lose between 5 and absolute maximum 10% of their body weight, which is not a huge ask. A small reduction in their total kilojoule intake, around about 2,500 kilojoules per day on average will certainly help people to lose approximately half to 1 kilogram a week. It's not, as Mark said, the biggest loser. It's quite a moderate amount, and you can do that through small incremental changes to your diet and increasing regular physical activity rather than dramatic changes. So people can achieve those, it has been shown.
What about exercise, Mark? Because, I mean, isn't exercise easier to do than changing your diet? And I thought the evidence was stronger, particularly with weight training. The Melbourne trial, which showed weight training was very good at preventing it.
Yeah, well, certainly exercise is an important part of prevention, and these things are a bit of a chicken and egg situation. One of the impediments to people doing exercise, though, can be overweight. People who are morbidly obese, in particular, can find it very difficult to achieve adequate levels of physical activity. They're the people that tend to be very sedentary and very at risk of developing diabetes at a young age. So. But the evidence around physical activity is very strong, and we need to be finding ways of tailoring not just diet but physical activity programs to people's needs, and that's going to be very different depending on people's own life circumstances.
Now, actually, we're talking about two separate things in this program. We're talking about population interventions as well as individual interventions, but if you look at population interventions to change the whole community rather than people who are at risk, tough ask, particularly in Aboriginal and Torres Strait Islander communities.
It is a very difficult thing. I mean, you have to look at the whole dynamics of the society that we work in. There are many, many other social problems and financial problems, etc. And asking people to exercise often becomes a very, very big ask. One of the points that I want to emphasize, and I don't know whether the other panel members will agree with me, is that yes, weight loss is very important, but the message I try to give to patients is that even maintaining their current weight is very, very important. Even if they maintain that weight and not gain the weight, it does have beneficial effects in the long-term progression of the disease.
Now, in gestational diabetes, the recommendation in the NHMRC guidelines is don't bother identifying women at high risk. This is a waste of time. You're going to miss up to 50% of women with gestational diabetes. You've got to screen every pregnant woman at 26 weeks or whatever it is for diabetes. So the question here is now, when we move away from population interventions to change whole communities, how you design them, exercise, all the stuff we talk about all the time, and look at individual interventions to try and prevent diabetes, if we go for a high-risk strategy, Alan, do we know how many people we're going to miss?
No, I couldn't answer that question. I think Mark might be the better person.
Yeah, it is difficult. We will miss a percentage of people, but and one of the reasons that we are designing simpler methods of screening people is to try and pick up as many people as possible, and I think we're going to talk about that later. But well,
we'll talk about it in a minute, actually.
Yeah.
So the guidelines recommend a screening strategy, and an intervention strategy to identify people at high risk, and presumably people who are pre-diabetic.
Yeah, yeah. So we're interested in identifying people with pre-diabetes, diabetes, and people who have equivalent risk. So that's why we've moved from our previous recommendation in the general population, which was to screen people from the age of 50 up, and some other groups of people at an earlier age, to really trying to bring that age down quite a bit to 40, and screening them using a diabetes assessment tool.
This is an absolute risk tool.
Yeah, AusD risk tool, which is based on the AusDiab study and really calculates people's risk. You get a risk score based on your answers to a set of questions.
And it's a heck of a lot younger than that if you're Aboriginal or Torres Strait Islander.
Yeah, Aboriginal and Torres Strait Islander, we're talking about 18 and up. So, and there are some other groups as well that have equivalent risk. So we're recommending that people be screened with that from the age of 40 and Aboriginal people from 18. And those people who have a risk score of 15 or more, not only should they have a fasting plasma glucose to determine whether they've got diabetes or possibly impaired glucose tolerance, but also that those people, regardless of their glucose, require an intervention. So require a lifestyle and physical activity intervention of the sort we were just talking about earlier. And that's where, you know, we've got the possibility of intervening early and picking up some of those people that were missing previously.
So let's just take a couple of questions. Karen Van Riet, I think is her name, has asked about, could you please name some of the studies in primary prevention?
Well, there's the studies that probably best known. The original study was a Chinese study. The Pan was the first author of the paper that announced that to the world. There's been a study in Finland, the Timoletto study. There was the US diabetes prevention trial, and the Indian study, which was another large study. All of these studies focused on people who were high risk and had impaired glucose tolerance, impaired fasting glycemia, and trying to prevent those people from going on to develop diabetes. Otherwise, we're looking at about at least 2/3 of those people over a 10-year period going on to develop diabetes, and we're able to prevent, as said earlier, about 60% of those people from doing so.
And the results of our poll 2 are in, and most of you claim to have either a comprehensive or moderate understanding. A couple of questions coming in by our webcast from David Menzies in Victoria, general practitioner in Victoria. Current diabetes prevention initiatives are struggling to attract participants, especially in the younger age groups. How do we convince young, busy people that are at risk to adopt lifestyle change when they perceive themselves healthy? The OSD risk is picking up people, but they're self-selecting out due to lack of urgency. Alan?
That's a very good question. I think people don't really recognise the symptoms having any immediate effect. It's a long-term condition where they'll be having complications 10, 15, 20 years down the track. So I guess we can focus on perhaps some of the initial feelings of feeling better, more energy, a general feeling of well-being, and perhaps some quality of life type of things. So accentuate what people will feel is some immediate benefits, and maybe then talk about some of the complications. Perhaps
How do you motivate people?
I think one of the important things that people forget is
shout at them.
that we are far too glucocentric. In today's world, in 2009, I would define diabetes as a vascular disease in which hyperglycemia plays an important role. People don't realize that even if they have sugars in the normal range, that you can still end up getting severe cardiovascular complications, and that has been well seen both in the IFG and the IGT state. And I think that's one of the biggest motivations, that is just not the glucose, it's the other systems in the body that are being affected. And I think that's the way to go, and that's how I talk to my patients, that diabetes is a vascular disease.
Mark?
Yeah, I think this is a challenge as we move away from the somewhat artificial situation of a trial, and they've even found this in Europe as they've sort of tried to take what they learnt in the Finnish study and apply it to population, the whole of European population level. They've had the same difficulty, and I think it's a question of, some of it's a question of logistics, getting people to programs, you know, enrolling them and linking them up, and that's something that we've really got to do a lot more work at getting to work seamlessly. But it is, motivation's a big part of it, and this is a key role for the GP, for the practice nurse, for the diabetes educator, and the dietitian, other people in the community to really work with people using motivational interviewing strategies and really help them to make a decision to make a change. And that's not something that's easy to do, and it's probably not something for many people that will occur in one consultation. It'll be kind of slow water torture that you really have to keep returning to this and say, look, you know, last time we saw you, your risk was high. You haven't yet got diabetes, but it's only a matter of time if we don't do something about it. So keep revisiting it and keep encouraging people. This is a long-term problem, and it's a long-term strategy we're going to have to deal with it.
Okay, we'll come back to the algorithm later about what you do when your OSD risk is high, yeah. But just to signal, part of that assessment is your cardiovascular risk and intervening then. So presumably you've also got to apply one of the cardiovascular absolute risk tools too.
Yes, absolutely. I think that diabetes cannot be assessed separately from any cardiovascular risk. So whatever cardiovascular risk tool that we use has to be applied simultaneously.
Another question from Queensland. Is there any evidence that people who do shift work are more prone to diabetes and stroke because of the changes that are required of the body, or is it simply that they choose the wrong foods and that becomes a risk factor in itself?
There's an association with lack of sleep and diabetes risk. There's an association between sedentary lifestyle and poor diet with diabetes and diabetes risk. So it certainly puts people in a higher risk category, given the way most shift work works. But it's not something that's not changeable. It is possible to work in shift work and to still engage in enough physical activity and have a reasonable diet, and that will make a big difference to your risk.
I might just go to our next poll question, which is how frequently do you screen your high-risk chronic disease patients for type 2 diabetes? 6 monthly, annually, third yearly, depends on the patient. So we'll come back to that later. And Beverly Smith asks us, are HIV positive patients a high-risk group?
Well, there has been some wonderful work done from this part of the world, particularly from the St. Vincent's Hospital.
So this is the protease inhibitor story.
Yes, that's right, with the HIV and the lipodystrophy syndrome, what you see from Professor Don Chisholm's group, where they have shown that patients with HIV have the same sort of metabolic facets as you would see in the metabolic syndrome, which is central adiposity, dyslipidemia, dysglycemia, etc. So yes, the answer to your question is they are at high risk, and particularly some of the medications may also interact with this metabolic syndrome configuration.
And if they change the heart makeup, you know, the highly active antiretroviral therapy, and they change that, is it reversible?
I don't know. I have no straightforward answer to that question. But certainly, when you are treating these patients, you've got to treat the metabolic factors as well, and that's what we do.
Let's go to our first case study. Joe's 27 years old. He comes to see you, Mark. He's a truckie, a smoker, likes to have a few drinks with his mates at the weekend. There's a family history of type 2 diabetes, and he's pretty overweight, verging on obese, and he comes for his annual medical that he has to have to maintain his license.
Well, he's certainly at risk of developing diabetes. Maybe not immediately, but certainly over the next 10 to 15 years, he's at risk of developing diabetes. It obviously depends on his level of obesity, and particularly his central obesity. So I want to be assessing his weight and body mass index, his waist circumference, looking at all those other risk factors which are part of the odds risk tool, such as you know, his ethnicity and whether he's got and his diet and physical activity.
And I think there are additional risk factors that we didn't talk about that aren't part of the risk factors.
Yeah, I mean, he won't have polycystic ovary disease, but
he'd probably thump the daylights out of you and suggested it.
He certainly could have, if he's had a cardiovascular event, for example, that puts him in a high risk category. So I want to really assess his risk factors, his overall risk of both cardiovascular disease and diabetes, and I'd be wanting to I have a real discussion about that with him, rather than leap in and do a blood glucose straight away, a fasting blood glucose. One of the problems with him is that if we do a fasting blood glucose, as was pointed out, I think one of the questions earlier, is that he might well have a normal glucose, but he's still,
So that's the value in the absolute risk tool.
Yeah, he's still maybe at risk of developing diabetes over the next 10 or 15 years. And we need to sort of look at him and say, well, if you're 40 and you've got these same risk factors, what's your chances of, what's your risk score, what's your chances of having diabetes or at least pre-diabetes, and what's that going to mean?
So Mark's a very multidisciplinary GP, Alan, so he refers young Joe to you for lifestyle modification. Absolutely,
and I think being a man, we wouldn't be focusing so much on his weight, but getting him into shape and getting him to lose a few pounds so that it looks a bit buffer. focusing on a moderate reduction in his kilojoule intake and really making some simple changes so that he can really implement them into his everyday life. We all know
Pretty
that
tough if you're driving a truck.
Exactly, I was just about to say that. On the road all the time, long hours, restaurants out there in the rural and remote areas maybe don't have the best choices that we would be recommending. So I think someone like
Chico rolls, what are you complaining about?
That's right. So I think something like one of those plug-in refrigerators that you can stick into the cigarette lighter would be a great tool for him. And he could then put in some sandwiches, maybe some snack foods, something from home, some fresh water, perhaps filtered water because it's cheaper and it tastes better, doesn't have a taste, unlike some of the tap waters around. Things that he can have on the go. Also getting him to perhaps try a reduced alcohol beer rather than the regular beer. So he's just cutting back a little bit, but not telling him not to drink at all, of course. That's pretty unlikely at his age. Just trying to get him to cut back a bit, maybe try and stick to 2 standard drinks a day if he can, and not save it all up for Saturday night, of course. And the other thing is perhaps trying to get him out of the truck and get him to do some physical activity. So maybe even walking around the truck to inspect it, make it looking conspicuous, going for a walk at lunchtime or perhaps before or after he goes out for his drive as well. So there are lots of little things you can incorporate into his lifestyle without putting him on a diet as such.
Motivating him, Hashim, a 27-year-old who thinks he's invulnerable?
Well, difficult, but we've got to do it. I mean, I just did a quick sort of OSDAP risk score on him, and he's in the moderate risk group, and his chances of developing diabetes is 1 in 20. So it's fairly high. So I think that if we give that kind of message...
And I suppose you could hang the thread of, one day he might be on insulin, which is not a great idea if you're a truck driver.
Yeah, we don't like to use insulin as a threat. As an endocrinologist, we
Absolutely
never...
not. This is part of the normal course of diabetes. Thank you very much for correcting me on that. So your objectives here, Alan, are moderate weight loss, is that right?
Absolutely. We need to lose about 5 to 10% of the initial body weight. So if he was 100 kilos, just 5 or 10 kilos. We're not going for the biggest loser. It's not, 10, 20, 30 kilos within a few weeks. It's about half a kilo, maybe up to a kilo a week. And the other important thing to point out is that we know that people do well if they see a practitioner on a regular basis. So if we see either the doctor, the local dietitian, the physiotherapist, the diabetes educator, all the team working together, providing consistent advice will certainly help the individual to comply with our recommendations and to keep up those behavioural changes for the long term. That's really important.
And I suppose some telephone contact, Mark, particularly if you're in a truck, you can... I suppose dealing with the mobile phone, but I mean, there is a way of mobile. Maybe. Some people are actually trying to intervene.
I think the important point here is also the consistent message which Alan brought out. That whoever is giving those messages has to be consistent.
Absolutely.
In a real life situation, we see that people are getting different messages from different sources. So that's very, very important.
Which weight loss diet is better, Alan? You've had a look at that.
Yes, well,
plenty on offer.
Our group, there's many diets on offer, a new one every week, I think. Our group looked at 4 of the more popular ones that were in Australia over the last couple of years, and you'll recognise these. The one in yellow is really what's a standard weight loss diet that most people, up until fairly recent times, would have been recommended. It's high in carbohydrate, it's low in fat, moderate in protein. The blue one is the low GI diet, which is essentially the same as the high GI diet, except that the carbohydrates that are chosen are the low GI options. The high protein diet is essentially the CSIRO total wellbeing diet, which has been very popular in Australia. And the green one is the Atkins style diet. And despite what people might think, the low GI diet and the wellbeing diet were actually almost equally as good and better than the Atkins style diet, and definitely an improvement over the standard weight loss diet as well. You can see both of them leading to a fairly significant decrease in fat mass, which is of course very important. It's not just about losing weight, it's what you are losing that's important, and losing body fat's most important. And of course the other factor that sets the two apart is that the high protein diet actually caused a slight increase in the LDL cholesterol relative to the low GI diet. And it is worth pointing out that in this particular trial, the people were provided with very lean cuts of meat. So it wasn't fatty meat, it was still a very lean meat, but they still had that slight rise in LDL cholesterol. So overall, the low GI diet was a superior system for losing weight for these people.
Another question that's come in, also from Queensland. Considering how many children are now obese, should we be screening them also?
It's a good question, but the evidence points otherwise. Where people have done screening for type 2 in children, the yield has not been great. And people believe, the experts believe, that children actually don't remain in a state of pre-diabetes for a long time. So you have normal glycemia one day, and within a short span of time, they develop frank diabetes. So we don't have a definite answer to that question, whether we should screen children. Some work that we did in the Torres Strait and has now been published, we have shown that 44% of the Torres Strait children have got some aspects of the metabolic syndrome. So in that particular very high-risk group, what we have tried to introduce is screening for diabetes as a part of their routine health check and not as anything different. Now that brings to the question, very interesting question, what would be the best screening tool? And in the new guidelines, people have suggested the point-of-care testing with glucometers, as well as, and somewhere down the line, once we get a sort of agreement about the HbA1c methodology, probably the point-of-care testing with glycated hemoglobin will facilitate matters and will be easier to do from a finger prick. But at this stage,
it's evidence-free territory.
It is evidence-free territory that screening for children for type 2 really hasn't shown much help.
Yeah, I mean, I think the most important thing we need to do with children is to assess their levels of physical activity in their diet and to really talk through with the parents about what we can do with that. And that's not very sexy, but it's what we need to do. It's probably the most evidence-based thing we can do with children.
And just give us a dietary checklist. I think we've got a dietary checklist for people.
Yes, we certainly have. Just a few points to jot down. Eating regular meals throughout the day is very important. I do find that a lot of people that are overweight tend to skip breakfast and sometimes even lunch and have the gut-buster meal in the sort of evening time, which sort of starts around 5 and seems to go to about 8 o'clock at night or longer. So it's really important to spread that food out evenly throughout the day as much as possible. Generally speaking, I recommend 3 main meals. Snacks are a little bit of an extra. A lot of people just eat them out of habit, and it's an easy way of cutting out that 25% of calories that I talked about earlier, just by dropping those snacks altogether. As you saw from all of those diabetes prevention studies, reducing total fat intake was the primary goal, and because fat is the most energy dense, it's one of the easiest ways of reducing the kilojoule intake in the diet as well. And of course there are lots of low and lower fat products out there in the market. When you do eat fat, of course, we're not saying have a no-fat diet. That's impossible and definitely unpalatable. So we're saying eat the quality fats instead of the saturated and trans fats that you find in meat and a lot of processed foods, and have the healthy poly and monounsaturated fats like you'll find in olive oil and canola oil and products made with those. Now, I think most people think that diabetes and developing diabetes is related to sugars, but really there's very little evidence for that. And what people need to do is avoid both the refined sugars and the starches, and it's the refined ones that are the problem. So obviously foods like milk and yogurt are quite high in milk, as is fruit, but the sugars in those particular foods isn't as bad for you as a lot of the other ones. Having high fibre foods, of course, will fill you up, and often they're the whole grain ones so that they're more slowly digested. Getting back, I guess, to the first initial point is to have carbohydrate at each of those main meals, so at least breakfast, lunch and dinner. And lastly, to make sure that those carbohydrate foods are the low GI or low glycemic index options. They're the best ones to have if you've got a risk of diabetes.
Now let's look at our, I suppose you could call it a second case study. This is moving on to the topic of exercise, because there is randomised controlled trial evidence that exercise can make an enormous difference. There are prospective studies showing that exercise can indeed abolish the risk of diabetes, and a randomised trial in Melbourne showing that weight training can reduce the progression to diabetes in people with pre-diabetes. This is a program developed by Diabetes New South Wales, and it's titled the BEAT-IT program. It targets fitness trainers developing exercise resistance and cardiovascular training. In this case, what we're going to show you is people with type 2 diabetes, but it certainly would work for people at risk of it.
My name is Bronwyn Penny. I'm an exercise physiologist and the lifestyle programs manager with Diabetes Australia New South Wales. The BEAT-IT program was actually something that was designed by myself for exercise professionals such as personal trainers and exercise physiologists.
Whoa, hello, well done.
It's an education program about diabetes and exercise and how to suit the needs of somebody with diabetes or people at risk.
Where you go?
From some of our research that we looked at, we know that a lot of people with diabetes are exercising in a gym environment under the care of personal trainers. The problem with having personal trainers is that their understanding of diabetes is not necessarily at a level that provides a safe environment. So the trainer training program covers some of the severe complications, so hypoglycemia, exercising with high blood glucose levels as well, so hyperglycemia, and also looks at some of the long-term complications that can affect people with diabetes, and that will in turn affect their ability to exercise safely.
Where you go? Keep it up. You got a minute left.
There are some programs out there that do similar things, and so there are a lot of gentle exercise for older adults. But all the research and evidence base suggests that people with diabetes are actually more than capable and safe for doing higher intensity physical activity, and that they actually get better results in terms of blood glucose control and diabetes management. So our program combines aerobic physical activity and quite heavily loaded resistance training.
How's that feeling, all right?
The other difference between this program and a lot of the other programs is that it's underpinned by a behavioural change approach. So initially when somebody comes along to do the program, they're actually involved in an initial physical activity consultation, which does not only looks at their health status and those types of things, but also discusses their goals, their barriers to exercise, because we know that people will get better results when those aspects are included as part of a program.
This leg has to be free like this, it has to be standing free. You can wobble, but the moment you start to jump around, you're out.
We actually piloted the program just to see how effective it was at a few different sites, one of which was Bundanoon at the Solar Springs Health Retreat, and we had some really, really brilliant results down there.
When Diabetes New South Wales approached us about doing the program, I initially thought, where are they going to find 24 diabetics in Bundanoon? We're just a little village an hour and a half south of Sydney with 1,500 people. And I was just so surprised at the initial information session that we had that there was 50 people turned up. So it was just incredible that just in a little community like ours, there were so many people that we could potentially help.
Away we go.
We started with 2 groups of 12 participants meeting twice a week for 12 weeks. And because that was so successful, we've continued those classes on a regular basis.
And 2. Last one. Have a rest. No, we won't. Stand up. Have a rest.
Before I did the program, I knew that diabetics had a problem with their blood glucose levels to do with lack of insulin production, but I didn't know that there were so many different complications. So what the program taught us initially was all the complications that may occur. Also, we looked at exercise contraindications, because there's some things that diabetics can't do.
And then put it up a bit more, so that'd be great.
We learnt that they have conditions such as peripheral neuropathy, which is a lack of sensation to the feet. So we have to be really careful where they place their feet, because we don't want them to trip or fall. The other thing, because many diabetics have heart conditions, they might be on medication that lowers their heart rate or lowers their cholesterol. So we can't measure their heart rate as we would in a normal class to see how hard they're working. We've got to use a scale of perceived rate of exertion. The great thing about the Beat It program is that it is affordable because it's a class situation, so that you're not paying exorbitant personal training fees. It can be done in any facility. It can be done in a hall, as long as the facilitators have Dynabands or small little hand weights.
Do some bicep curls.
When we actually deliver the training package to personal trainers, you have to have your Cert 4 personal training certificate. It's delivered by accredited exercise physiologists, accredited practicing dietitians and diabetes educators, so they're getting all those aspects when they come along to a training program.
The program has been extremely successful. We did quite thorough testing before the program, both clinical testing and also functional testing, and the results have been fantastic. We not only have seen a lower blood glucose level, also exercise helps with weight management, and weight loss is particularly important to diabetics. If they can manage their weight, in a lot of cases, they can manage their diabetes.
Excellent.
We have a participant, Grant, who has had fabulous results. His blood glucose and his blood pressure have both dropped, and his aerobic fitness has increased.
Well, certainly, the HbA1c's dropped down from 8.9 down to 7.3. My insulin doses were increasing, and now my insulin doses are decreasing. So as my control is improving, I may even be able to drop some of the medication as well. The greatest thing is I'm now much more motivated to actually get out and do the exercise. So I now walk 4 to 5 days a week. I'll do some of the exercises that we've been shown to do at home. And I'd looked at joining gyms before in the past, and I guess my problem was that you feel inadequate when you look at the bright young thing. So I think coming here with a like group of people, that was great because everybody's in a similar situation, so we're all motivating each other.
The other aspects that you look at is the social and emotional health and well-being. So they're things that you can't always necessarily quantify through a physical activity test. So we did an SF36, which is just a general health and well-being survey, and we showed some really, really dramatic improvements in the quality of life that people experienced after finishing the program.
And so that mark could work for people at risk as well, even though that's people with diabetes.
Yeah, I think exactly that sort of program is what would be appropriate intervention for people with high diabetes risk, people with IGT or IFG.
Let's go to the answers of our third poll question, was how frequently do you screen your high-risk patients for type 2 diabetes? And the answer is the overwhelming majority do it annually. Nobody does it third yearly, but some of you say it depends on the patient, and 6 monthly is the other group. What do the guidelines say?
Well, the guidelines say that we ought to be screening the population every 3 years from, for example, the age of 40, in terms of using the OzRisk tool and so on. Once people are identified as being high risk, so having an OzRisk score above 15, then we really need to be following them up on an annual basis.
So our audience is well informed. Question from Roscoe Taylor in Tasmania. Looking at the longer term outcomes for weight loss programs, do we really have good evidence that sustained weight loss occurs for periods longer than, say, 12 months?
There are some studies that go beyond 12 months, but they're not as large a number of them as we'd like. But there certainly have been a number of trials that have gone up to 5 years, for example.
I think the biggest evidence comes from the Finland study.
Yeah.
The Finland study is still going and people are still continuing to lose weight. And it's gone beyond 5 years.
Without continuing intervention?
Yeah, with just the lifestyle intervention that people have done. Yeah.
Yes,
yeah.
up to 5.
So yeah.
Yep. Because the Finnish study is what, a 5-year follow-up without further interventions is still showing weight loss.
Yeah.
Question from Brian Boring in Tasmania. Is there a need for a diabetes risk factor assessment via a general practitioner or nurse, an MBS item for it that would include evidence-based assessment, such as the OSD risk assessment questionnaire?
Well, yes, I think so. I think there's already an item number for GPs doing an assessment in people who've completed the OzRisk tool, but I think it's this whole area of risk assessment is something which is ideally suited to the role of the nurse. I don't think it replaces the GP, so I think there's still some things that the GP will need to do once people's risk has been assessed. But working through the risk assessment with patients is something that would be ideal for a practice nurse to do. So the problem that we've got is that's really only available for people at the moment between 40 and 50, and it should continue to be available. In fact, it should be available for some younger groups who are at high risk as well.
And let's say you put somebody on a lifestyle program, what sort of monitoring, apart from repeating the OSD risk tool every year, would you be doing on somebody to monitor their progress?
So this is someone who's got a risk score of 15, yeah.
Yeah, who but is not diabetic, and you're just putting them on a lifestyle program. How are you going to monitor them?
Well, I think
what parameters?
You need to repeat their OzRisk score, but I think you want to do annual fasting glucose, because some of those people, despite your best efforts, maybe because they're unable to follow the lifestyle program, will go on and develop diabetes or in fact measurable impaired glucose tolerance or impaired fasting glycemia.
So let's go through the protocol now. Just let's remind ourselves about who gets screened, the OSD risk again, and also those extra risk factors, and then what happens with your blood sugar testing.
Okay. So the first thing is to screen everyone from 40 up.
Or 18 up if you're
or if you're a Aboriginal or Torres Strait Islander from 18 years of age. All those people should have the OzRisk score assessed, and if they've got a score of 15, they need to be tested with a fasting glucose and be referred to a lifestyle program. regardless of their fasting glucose. So even if they've got a fasting glucose of 4 and they've got a risk score of 15, they get referred to a lifestyle program of some sort. But there's a number of other groups that are high risk, independently of their Oz risk score. Anyone who's had a previous cardiovascular event, such as myocardial infarction or stroke, women with history of gestational diabetes, women with polycystic ovary syndrome, patients on antipsychotic drugs, for example, olanzapine, or risperidone, and those with impaired glucose, who've had a previous impaired glucose tolerance test which has been abnormal, or have got impaired fasting glycemia previously. All those people we can regard as being at high risk and warranting yearly at least follow-up, assuming they don't yet have diabetes.
Some people are arguing rather than a fasting blood sugar you do a glucose challenge, which is not quite a glucose tolerance test, but it's another form of screening. But the guideline says a fasting blood sugar if you've got a high OSD risk score.
I think the current evidence is in favor just of fasting blood glucose. The only situation where we will do a formal oral glucose tolerance test is when your fasting blood glucose is between 5.5 to 6.9. And that's the only situation where we'll do a OGTT, not a challenge test, but a proper 75-gram glucose tolerance test.
Okay, so your fasting blood sugar comes back at under 5.5. What do you do?
If you have a high risk factor, I think you have to repeat it and make sure that, just not base your assessment on one single blood test, because, if it is 5.4 and your risk screening is high, then you've got to repeat. We know that there is a day-to-day variability in fasting glucose. And look, you are giving somebody a diagnosis or no diagnosis for the rest of their life. You've got to make sure, just like what we do for diagnosis of diabetes, if we have one sugar more than 7, we make sure that the sugar is repeated.
So you've answered that for diabetes. If it's over 7,
you repeat it.
And then it's a diagnosis of diabetes.
Yeah.
And if it's 5.5 to 6.9?
We'll do a OGTT. I certainly, in my practice, do a OGTT in that situation.
And if that's marginal, repeat in a year?
Repeat in a year.
Okay, so we've got somebody on a lifestyle program. When would you think about drugs? Metformin, for example. I mean, metformin is going to probably lower their weight and make them more insulin sensitive. Why wouldn't you just...
Yeah, I think it's a second best choice. First of all, it's not actually approved by the TGA for that purpose, for diabetes prevention in Australia. But more importantly, the evidence is that diet and physical activity and weight reduction is a better strategy. It's a more effective strategy at preventing diabetes.
If they do it.
If they do it. But and I think we shouldn't be fatalistic about this. One of the things which influences how effective we are our outcome expectations as clinicians. So we need to be positive about it. And it's still our first choice. Trying to get people to lose weight, using medications to lose weight can be effective, but the problem is people often regain the weight when they stop the medication. So, that's... It's again, it may be worth a trial in some patients, but it's...
I mean, one of the issues here, though, isn't it, Ashim, is that it's a line in the sand where we say it's diabetes. It's pretty arbitrary, and there's more and more evidence coming out that anything over 5, you're really at risk of microvascular complications, including macrovascular one. It's a pretty... we might be in a situation, if we're talking 10 years from now, they redefine diabetes as 6.5.
I think, yeah, we're just drawing arbitrary lines. I mean, coming back to the drugs again, we have to dissect, Norman, what the drugs do. Do they actually prevent diabetes, or do they delay the progression? And I think the diabetes world is coming to grips with that. While several drugs...
either's okay, isn't it?
Yeah, either is okay. But I think that it's more towards delaying the progression rather than preventing the disease. And coming back to your
But isn't that true of lifestyle as well?
And yeah, that's right. And the other question is that, you've said that where do we draw the line? The clock starts to tick very, very early. And macrovascular disease have been shown in people even within normal glycemia.
So what's the role? I mean, there have been trials. For example, the George Institute did a trial suggesting that if you have got a diagnosis of diabetes, you should certainly just be on statins and antihypertensives regardless of your level of cholesterol or blood pressure. What's the story with pre-diabetes in primary prevention here in terms of when you would start a statin or an antihypertensive?
I don't think that we have any evidence for that in pre-diabetes at this stage.
Yeah, I think we have to look at people's, the point you made earlier about looking at people's cardiovascular risk.
So you do a cardiovascular absolute risk tool.
Absolute risk score. Now, one of the problems is, of course, that's driven by whether you say people have got diabetes or not, because that increases their risk. But certainly someone who has someone who has impaired glucose tolerance and has got a borderline absolute risk score, I'd be erring on the side of putting them on an antihypertensive and a statin.
A question from Catherine Jones in Casino in northern New South Wales. Would OSD risk screening be beneficial in aged care?
Yeah, I think it's useful at any age, really, although...
what age is it validated to?
Well, it's only validated because of the AIHW study up until the age of 70, so we really don't have much evidence beyond that. And of course the problem in aged care, particularly you've got cognitive problems and so on, so and your scope for preventing people from eventually developing diabetes may be less. So I think either AusDiab risk score or probably preferably I'd go straight to a fasting glucose in people in aged care. So we're talking about particularly people over the age of 75.
So I've no desire to bankrupt the Australian healthcare system, but what about bariatric surgery as primary prevention? Professor Sinha?
I think we've got to be very careful with the bariatric surgery story. While the data shows that particularly from the Swedish obesity study, that people in a certain category, particularly BMI more than 50, they have been shown to decrease mortality, which is the most interesting data, as well as reversing diabetes. It cannot be a panacea for everybody because, as you said, that the Australian system will go bankrupt. I think lifestyle should still be the first choice.
And it's more the bypass operations that seem to be...
And then again, there is the question of what surgery you should do. There are surgeries which decreases the volume of the stomach versus surgeries which has other mechanism of action. So the Roux-en-Y bypass has been suggested as probably the preferred mode of weight reduction surgery in people with morbid obesity more than 50, whereas people who are less morbidly obese can have the gastric
there's this new operation which is unproven so far, which is the sleeve, which is some sort of metabolic thing that happens if you bypass.
So the whole question of bariatric surgery, its cost effectiveness, although there has been a very recent study which has just been published from the UK, which does show that it is cost effective. But then again, we have to look at the particular scenario where we are going at.
And I think it's very difficult for clinicians because you certainly see the benefit, particularly lap band surgery.
But you also see people who liquefy their eggnogs and
exactly,
still...
Yeah, and you also see the effect that has on people's lifestyle long term. So we want to, if we're going to use bariatric surgery in people who are morbidly obese, we want to do it at a young enough age where we're going to get some real benefit out of it in terms of preventing diabetes and cardiovascular disease. But we need to think that, if we do that in a 30-year-old, our case example from previously, that if you did it at that age, there's going to be potential for a lot of, you're going to have to manage that person for the rest of their life. That's significantly
That's the scary thing about lap banding, is that there's no exit strategy. You've got to maintain them forever. Job for life.
Yeah.
So the key message here is don't forget primary prevention.
Yeah.
Screen your patients. What are your messages for people to take home, Alan?
Don't go on a diet. Make small changes to achieve long-term goals. So small amounts of weight loss by changing your diet in a small way that's achievable.
And sustainable.
And sustainable.
I think the evidence is for general practice in particular that we can be most effective with that high-risk group. So it's finding the people who are high risk and really trying to offer a lifestyle intervention to those people, as well as obviously ruling out diabetes.
As well as advocating for population-based changes as well.
And all the other things we've talked about.
All of the above plus. Hashim?
I think as an endocrinologist, we should be working more closely with our general practice colleagues. Just because we are specialists, we don't have to take that step of not looking at primary prevention. We should definitely, if we had to stop the tsunami of diabetes is no longer an epidemic. It's now a tsunami. I think primary prevention is the way to go. And early detection, early treatment, and treating diabetes as a vascular disease is the way to go forward.
Thank you very much to you all. And I hope you've got a lot from tonight's program on type 2 diabetes and primary prevention, case detection, early diagnosis. This series of 4 programs, which is what it will be available in December, free on DVD. And if you want to order the set, visit the Foundation's website at rhef.com.au. And if you're interested in obtaining more information about the issues we've raised in the program, there are a number of resources available on the Rural Health Education Foundation's website. And I'll say it again, rhef.com.au, including links to all the new type 2 diabetes guidelines. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Fantastic that so many of you were involved, and thanks for all your questions. I'm Norman Swan. I'll see you next time.